Hello, Candid Conversations. So for those of you who might be new to our YouTube channel or the first time listening to one of our podcasts here, my name is Molly Maidenblick. I am the Government Relations Director for ACS-CAN, the American Cancer Society Cancer Action Network. But for those of you who might be regular listeners we have a monthly podcast, but then we also do have kind of these special edition podcasts, as I like to say. So this is one of our candid conversations. So we take a little bit different approach to these, where you're not listening to just me kind of give an update on the state and federal issues, but we have very special guests today that we are talking on a very specific topic, one that I'm very excited to learn more about myself, but also for our listeners to learn more about. So we are talking about CAR T-cell therapy. So if you have not heard of it, that's fine. Listen, and you'll learn a lot more about it. I learned a lot just listening to the two individuals that we have on our podcast today. So we hope that you enjoy this special edition candid conversation that we have. So first, I am going to introduce our first guest, Dr. Diol. He is a program director of the Hematology Oncology Fellowship Program and a member of the Malignant Hematology and Bone Marrow Transplant multidisciplinary teams at the Barbara Ann Karmanos Cancer Institute. So I'm going to add him here and he can join us. So hello, Dr. Diol. Thanks so much for being with us.
Hi, Molly. Thanks for organizing this, and thanks to the American Cancer Society for putting this together and all the sponsors. And I'm glad to be here, and hopefully we can share some information about CAR T-cell therapy in general and what services we have to offer here at our Karmanos Cancer Institute.
Wonderful. Thank you. Yeah, of course. We really appreciate it. So thanks for bearing with us for a second. We're going to introduce our next panelist that we're also very, very excited to have. So Liz McSherry, she is a board certified nurse practitioner. She has an expertise in hematology, oncology, and palliative care. Ms. McSherry, she's been working on CAR T-cell clinical research and drug development for the last 2 years at Bristol Myers Squibb. So let's welcome her to the stream. Hello, Liz.
Hi, Molly. Hi, Dr. Diol. Thanks so much for having me. I'm excited. Thanks for the introduction as well. And just like Dr. Diol, excited to talk a little bit about CAR T cells.
Great. Well, again, just can't thank you guys enough. I'm excited about this just because, so for our regular listeners, they might remember Andrew Shepard. He was the government relations director before me, and he kind of is the one who started talking about this, and I didn't know a whole lot about it, to be very honest. So I was like, okay, well, let's get this podcast going so more people out there can learn more about it. So bear with me if I ask some silly questions that might seem obvious to you, but I'm hoping that there's some of our listeners might not know or have maybe the same level of education as I do on the topic. So if you don't mind, we'll jump right into it if you guys are ready.
Let's do it.
Wonderful. So Liz, I'm going to direct this first question to you. I'll give you an easy one to start with. How about that?
Perfect. All the hard ones you got to give to Dr. Diol.
Perfect. We didn't plan that, Dr. Diol. So what does CAR T-cell therapy stand for?
Oh, perfect. That's right in my alley. So CAR T-cell therapy, the acronym itself actually stands for chimeric antigen receptor T-cell therapy. So I guess I'll give it like a little bit of context.
Sure, that'd be great.
Yeah. So when patients are diagnosed with a cancer, and you're thinking about treatment options, I think treatment options can kind of fall into 5 different categories. I think the first 3 are pretty well understood by people, the public in general, and include things like surgery, chemotherapy, and radiation. Another category is a more novel or newer treatments that kind of emerged in the last 2 decades, drugs called targeted therapies. And these actually target genes and proteins that can help cancer cells survive and grow. So they're a little bit more specific. Or targeted therapies, exactly as the category would explain. And then finally, we have a group of treatments or drugs called immunotherapies. Mm-hmm. And immunotherapies in general are essentially harnessing the power of a patient's own immune system to either boost immune function or to help find and destroy cancer cells. And CAR T cells kind of fall under that immunotherapy category and actually do both of those things, kind of boost your immune function, and we're helping to specifically target certain types of cancer cells.
Okay. So a little bit of a follow-up. So you kind of obviously explained, what it means, but for someone who's can't follow all of that exactly, how does it work exactly? Like, what does it mean to like boost your immune? What is the therapy doing inside of a patient's body?
Okay, great question. So, CAR T cells are the concept of this of treatment is essentially re-engineering your own immune system. So we're specifically collecting T cells, and T cells are a part of your immune system and are pretty instrumental in that they help regulate and orchestrate your immune system. And they do that by doing two things. They kind of help activate other immune cells and kind of direct them and tell them what to do, and or they directly kill cells that are infected by pathogens or cancerous cells.
Okay.
So the process of CAR T cell therapy involves collecting a patient's their own T cells, re-engineering them in a lab to express this CAR structure on their surface. And the receptor on the surface of the T cell is kind of engineered or educated to look for a specific protein that lives on your type of cancer cells. Okay. So it's trained to look for it, find it, and ultimately kill it in a very boiled down.
Yeah, well, we appreciate that very much. Sounds so simple.
And
Yeah.
Just to add one more thing, in addition, I think to what Liz was saying, these cells, once they put into the patient's body, they also divide and grow and make more of themselves too. So they can divide. So it's like a living drug that's put into the patient's body and can divide once it's infused into the patient's body to be able to kill more of the cancer cells too.
Okay. So
hopefully over longer term. Yeah. Sure. Over longer periods of time as well. Yeah.
So correct me if this is a bad comparison, but I did watch The Magic School Bus growing up. And so when you're sick, you get white blood cells, and then don't they divide and you get more of them to like kind of treat an illness? Is that a poor kind of comparison, or is that an okay one from my simple, not doctoral brain?
That is what's happening. We're multiplying and growing your immune system outside of your body and giving it to you. And then once it gets inside of your body, we hope it does exactly what you just said, grow and multiply when it finds those cancer cells.
I'm so happy right now. Thank you for saying that. So
I know what episode you're talking about.
That maybe like, I don't know, maybe I'm expressing my age here, but I loved Magic School Bus. I'm not sure if they still watch that anymore. But anyway.
It's Miss Frizzle, right?
Yes, Miss Frizzle. I realized as I was saying, like, I'm showing my age. I don't mean to call either one of you
so
old,
much from that.
Yes. Okay, so let's see. I don't know. Maybe Liz, I might direct this back to you again. Are there any side effects with this therapy?
Oh, Dr. Deal, you'll probably do a better job of it than me since you're treating people more directly. But side effects can have a big range. There can be side effects that are mild flu-like symptoms, but absolutely can present in more serious forms. I think the large side effects that are most commonly, I think, talked about are inflammatory responses or neurotoxicity responses that are called cytokine release syndrome, which is kind of hallmarked by fever and low blood pressure and can affect a lot of different organ systems and cause organ dysfunction. And then the neurotoxicities associated with it can be like altered mental status, so confusion, altered speech, and even seizures. So it's really important when patients are getting these treatments to go and stay near these treatment facilities that have nurses and doctors that know what to look for and how to treat it.
Sure. Dr. Deal, did you have anything that you maybe wanted to add to that, or anything that you're seeing?
Just a few more things to add in terms of what Liz just explained. Those are the main side effects, but also when patients get this therapy, they need to get a gentle form of chemotherapy before to kind of make space for these cells in the body.
Okay.
So sometimes patients can have some side effects that are because of that in terms of mild nausea, vomiting. Usually
Sure.
these chemotherapies don't cause complete hair loss, but some hair thinning can happen, some fatigue and tiredness that can be associated. And then, like Liz mentioned, once these cells are put back into the patient,
Hmm.
they not only kill the tumor cells, but they get activated and they divide and recruit more of the immune cells to be able to do this killing of the bad cells. And as
Okay.
that happens, that leads to the release of a lot of the inflammatory chemicals called cytokines. And that leads to a cascade which causes some patients to develop very high fevers, low blood
Mhm.
pressure, low oxygenation. So that
Okay.
is the thing that is referred to as cytokine release syndrome that needs to be managed appropriately. So it needs to be first identified appropriately and managed appropriately.
Sure.
In addition, patients can have the neurological toxicity as the inflammatory chemicals cross into the brain. Some people can have swelling in the brain that can lead to some people just it's a mild confusion. They can't find the right words to describe something, all the way to the point to the far end where some people can have seizures or can go into coma if it's not recognized and intervene in a timely fashion.
Sure.
And then there are some long-term side effects that we monitor for with CAR T cell therapy, including some patients having low blood counts that sometimes can last for a few weeks to maybe a few months after the infusion. Again, we
Hmm.
think of it as an inflammatory reaction causing suppression of the bone marrow, which is not able to make the normal cells in normal amounts as it's needed.
Hmm.
And also, some people have low immunoglobulin levels that increases the risk for them to get infections after they recover from CAR T cell therapy. So these patients need to be monitored for infections and treated with prophylactic antibiotics or antiviral medications to prevent things like shingles for a period of time after they've gone
Sure.
through CAR T cell therapy.
Sure. Are these side effects actually? Would you are these side effects common for most patients that you see?
So some degree of cytokine release syndrome can happen in a lot of patients. Again, it depends on what there's a few different diseases that currently we use CAR T cell for, and depending
Okay.
upon the disease, there's different levels of what we see in terms of the
Okay.
cytokine release syndrome. But as the field has moved forward, as we've had more experience managing these symptoms, because initially when these CAR T cell therapies started off in clinical trials,
Hmm.
the concern was if you intervene too early to try to control the growth of these cells or the inflammation that they're causing, that
Hmm.
might lead to a bad outcome in terms of the cancer being able to grow back. But as
Oh,
we've
okay.
realized more and more that even if you intervene early and control the growth and all the inflammation that these cells are causing, it
Hmm.
really doesn't affect the long-term outcome for patients. So
Okay.
more and more centers are intervening early so that they can prevent the patients from getting severely ill. So a minority of patients can get severely ill from these treatments, but like
Hmm.
Liz mentioned, it is imperative for these patients to get treated at centers that have had experience and are certified to provide this therapy and live close to a or at least for a period of time are close to a hospital where they can be managed appropriately after
Sure.
they received CAR T cell therapy.
Sure. Yes, Dr. Deal, you had kind of mentioned like for the diseases that you will use this therapy on to treat. Are there certain, does CAR T cell therapy work on all cancers, or are there only some of them that it really works for?
So right now, the FDA approved indications are for a few different kinds of lymphomas. So that's diffuse large B cell lymphoma, follicular lymphoma, and mantle cell lymphoma that we have approval for CAR
Okay.
T cell therapy. For leukemia, it's a type of leukemia called acute lymphoblastic leukemia, which we tend to see more commonly in younger patients compared to older patients, not to say adult patients or older patients don't get it. But initial approval was in children and young adults, and now we have approval for older patients too.
Okay.
And more recently, the most recent cancer that we've had approval for from the FDA is for multiple myeloma, which is a malignancy that's seen in patients who are usually older in the 6th and 7th decade of life and who failed multiple lines of therapy. So those are the approved indications as of the current time for
Okay.
patients who might benefit from CAR T cell therapy.
Okay. Great. Liz, to kind of piggyback off of that a little bit. So, when would you say that CAR T cell therapy is an option for a patient for if they have the cancer that Dr. Deal just kind of had mentioned?
Oh, that's a complicated question. I think
Sure.
it is kind of disease specific. So he mentioned a
Mhm.
couple different kinds of lymphomas, the B-cell ALL. So
Mhm.
I think the best way to answer that is I think in general, a common perception is that CAR T cell therapy is kind of like a Hail Mary, last ditch resort when
Mhm.
your disease isn't responding to earlier lines of therapy like conventional chemotherapies, but that's not necessarily the case, and I think is actually really rapidly changing. It could even be indicated as soon as a second line therapy, which means that patients have received one line of treatment, their disease didn't respond to it, so CAR Ts could be indicated. So I guess to kind of piggyback off of that, I have in my notes to make sure we talk about early referrals. So I think, when you have a blood cancer diagnosis, talking to your physicians about CAR T cell therapy as an option is super important, because as Dr. Deal said, there's not every hospital in the United States is able to offer this treatment. And so there's a lot of logistics behind receiving CAR T cell therapy that need to be worked out usually in advance. And so those treatment centers can help patients kind of identify if and when CAR T cell therapy is an option, and if they receive that therapy in a clinical trial setting, or if they receive treatment potentially off clinical trial. A whole other can of worms gets open in either one of those settings.
Yeah. So both of you, I appreciate your answers, because I think what I'm, for somebody, I'm just thinking myself, let's say I get this diagnosis, right? And I'm just like, oh, okay, I have leukemia. So that must mean I go get CAR T cell therapy if I happen to know about it, right? But it's not, there is steps that your doctor will tell you about. You can't just kind of jump to it. And just because you are diagnosed with that specific cancer, that might not be the route that your doctor kind of recommends, but it's always good to ask about it. But that's kind of what I was kind of searching for in a roundabout way. So I appreciate both of your answers for that.
Yeah, I think it's important for the patients to make sure that they have an open channel of communication with the treating team to kind of discuss what are the options, because sometimes patients might feel, hey, so-and-so got this therapy and I'm getting a different kind of chemotherapy, but it might be a different type of cancer, how their cancer risk factors might be different, or how their cancer is behaving might be different. So I think every patient, we try to come up with an individualized plan for that patient. And to the point, in terms of CAR T cell therapy, usually most of our therapies in cancer, we start off with looking at patients who failed other lines of treatment. And that's usually where we try to come up with new options that the patients can benefit from. And as that becomes successful, then we hope that those therapies can move into earlier lines if they're really promising therapies, and more patients can benefit from them.
Right. Absolutely. Yeah. Thank you for kind of nutshelling that much better than I did. So, Liz, I'll go back to you. So this is going to be a difficult question for you. Well, maybe, but so how effective would you say the treatment is?
Oh, this is a good one for Dr. Deal.
Oh, okay. Do you want me to punt it? I can go back to Dr. Okay.
I'll give my I guess like one liner. I think CAR T cell therapy is really exciting. I still think that we're at the tip of the iceberg in really honing in how it can be super effective. But CAR T cells has absolutely demonstrated the ability to eradicate disease, and mostly in leukemias and lymphomas, and produce long periods of disease-free time. But again, this is so specific often to the particular type of cancer that we're treating, and where it falls in that line, and when a patient receives the therapy. There's like 400 or plus clinical trials open that are investigating the timing of CAR T cell therapy. And I do think that is affecting how effective the treatment is.
Sure.
And Dr. Deal, I'm going to punt the rest of it to you.
Sure. So I think the important thing to remember is that this is a therapy that showed really great responses in patients who had failed different lines of chemotherapy, unanticipatedly good results that we were not expecting to see as high of results. Theoretically, we hope for that, we wish for that, but in clinical life, we saw really good responses. So just for example, for lymphoma, for diffuse large B-cell lymphoma, when patients had failed 2 lines of therapy, there's 3 different CAR T-cell products that are approved and available right now in that setting. And the response rates for that, the initial response rates have been reported in the clinical trials anywhere from around 55 to around 80% or so of patients responding to the treatment. But what we see with longer follow-up in that patient population is that about 40 to 50% of those patients are cured of their disease. They're far out enough that we can think about that their chances of relapse are almost next to nothing, and they don't have a chance of relapsing because those patients have been followed long enough that if they were going to relapse, knowing what we know about the disease biology, they would have relapsed by now. And since we don't see relapse, we hope and expect that those patients are cured of the
Sure.
disease.
Sure.
On the other side, with some of the other diseases like multiple myeloma, we don't have as long of a follow-up. We do see high response rates in the 80 to 90% range with multiple myeloma patients who failed 4 lines of treatment prior to getting CAR T cell therapy.
Mm-hmm.
But again, this is something that is early days right now. We still have to follow these patients a little bit longer because in one of the studies that has the longest follow-up, the patients who got to MRD negative complete remissions, what MRD means is minimal residual disease or minimal
Okay.
measurable disease that you can get to. Even with that group of patients, at about a year and a half, about half the patients had the disease come back in
Mm.
multiple myeloma. So
Okay.
we're still trying to understand who are those patients who
Sure.
might get longer benefit, who are the patients who might relapse despite getting such a deep response, and
Mm-hmm.
what can be done to alter. And that's where I would like to put in a plug for clinical trials because that's
Yeah.
how we learn about how to treat patients better and help improve the outcomes, is
Mm-hmm.
to learn from our successes, to
Mm-hmm.
figure out how we can build on that success. CAR T cell therapy is great. It's really helpful. It's helping a lot of patients. But
Yeah.
how can we improve so that more patients can get benefit out of that?
Yeah, absolutely. I know that's something that the American Cancer Society and the American Cancer Society Cancer Action Network that we're definitely working towards, and one of our priorities, especially at the federal level of, yeah, how can we better clinical trials and get more people involved. So, but Dr. Deal, to kind of, forgive me if this was kind of encapsulated at some point during our conversation already, but how long has CAR T cell therapy been around? How long have we been using it?
So the first approvals for CAR T cell therapy were around 2017 or so.
Okay. Okay.
So it's been about 5 years since we've had commercially approved product that's been used and available. The clinical trials were done a few years before that. So around 2013, 2014 is
Okay.
when we had some clinical trials. There was small experience with CAR T cell therapy as far back as 2008, 2009, that initial work was started and some of the initial work was done that showed promising results that led to early stage clinical trials and then development. So it's relatively new in
Mm-hmm.
terms of how long it's been available
Yeah.
commercially, but the work that's been going on to develop this modality of treatment has been going on for a long period of time.
Yeah. So, can you speak to some of the advancements that we've already seen in CAR T cell therapy?
Yeah. So again, with CAR T cell therapy, one of the things, like I mentioned, initially we were all the treating physicians or the treating teams were wary of intervening early with CAR T cell toxicity because we didn't want the CAR T cells to stop killing the cancer and have the cancer come back. So I think one of the advances that has been made is that we've realized that early intervention to manage these symptoms that can be sometimes very severe if we manage them early and control them early
Mm-hmm.
don't seem to adversely impact the outcome of what we expect from CAR T cell therapy. So I think that's one of the big advances. And the second thing that is happening now is in this whole process, like Liz had mentioned before, there needs to be a lot of coordination that needs to happen between the patient. It's a team sport. The patient needs to play their part, their family members, the refereeing team, the team that's going to do the CAR T cell therapy. Everybody has to do their own job. And
Mm-hmm.
even when everything goes as planned, once we have approval for CAR T cell therapy, the patients need to undergo collection of the CAR T cells. So, like
Mm-hmm.
as mentioned, they go through a process when from their peripheral blood, these cells are collected and they have to be shipped off to a manufacturing facility. And that period of manufacturing can vary on the product anywhere from about 3 weeks all the way to about 6 to 8 weeks that it can take for those cells to be manufactured and shipped back for infusion. So there
Okay.
has to be some coordination during that period of time about what might be the optimal therapy that can keep the disease from taking off during that period of time when the patient is waiting or is becoming symptomatic from their disease. So there's
Mm-hmm.
a lot of research happening in that sphere to see what would be the optimal therapies around that period of time.
Okay.
Also, once the cells come back for infusion, once you infuse the cells, those patients, we're trying to see what we can do to minimize the impact on patients. So some of the centers, including us, at Hermanos, we've started, before COVID had started, doing this outpatient to try to manage this outpatient. And if the patients develop toxicities, then bring them to the hospital so that they didn't necessarily have to be in the hospital for that whole period of time waiting for one of the side effects to develop.
Yeah.
And also to try to shorten the period of time between when the patients need the CAR T cells to when the cells are available. There's now ongoing research looking at off-the-shelf CAR T cell therapies being made. So instead of using your own immune cells where you have to collect these cells, they have to go undergo manufacturing, come back. If you had a
Oh.
product that was ready to go when the patient needed it, so in that situation, again, it sounds more like science fiction right now, but we
Yeah.
can donor cells. These can be gene edited so that they don't recognize somebody's body as foreign, and then that piece of DNA can be incorporated where they can be directed to target a type of cancer and then be infused into the patient. So
Oh,
hopefully that will
interesting.
help shorten. And there's some research right now, even for patients' own cells, to be manufactured in a shorter period of time. So like I said, right
Okay.
now, the current manufacturing time can last anywhere from a few weeks to maybe a month and a half to 2 months. But there are now new studies that are looking at shortening with new ways of being able to have these cells get ready to receive the DNA into the cell and be ready for infusion in a much shorter period of time. At last
Interesting.
year's Annual Society of Hematology meeting, there was data presented on CAR T cells that were manufactured within 2 days of the procedure, the apheresis procedure being done. So hopefully
Okay.
all of those things will help improve the outcomes from CAR T cell therapies. And we're learning about new cancers that might have markers on them that can be targeted using the CAR T cell therapy specifically. Like Liz mentioned, the portion that's outside of the cell is what is used to target the specific
Mhm.
type of cancer. And that can
Okay.
be directed against different types of cancers if you know a marker that's expressed on cancer cells and not expressed too much on normal cells, and you can target that using CAR T cell therapy.
Okay. So you might have already just started touching a little bit on kind of where I was going to go with my next question here. So it sounds like maybe in the future that this treatment might be able to expand to other types of cancers. Is that kind of what you were saying there?
That is correct. Yeah. So
Okay.
right now we have those indications that we talked about, mainly in lymphoma and myeloma settings, so mainly
Mhm.
blood cancers. And
Okay.
there's a lot of interest in developing this therapy further in some of the solid tumor cancers like breast cancer, prostate
Okay.
cancer, lung cancer. So
Oh, wow.
uh, a lot of centers are working on clinical trials. At Kermanos Cancer Institute, we're collaborating with some of our solid tumor colleagues to have clinical trials in breast cancer, prostate cancer, and head and neck cancer to try to target some of those cancers using CAR T cell therapy technology.
Okay. So obviously we have not accomplished this yet. So this might be an impossible question, but as I was sitting here thinking and listening, so my example earlier of like the white blood cells, like multiplying and to fight off a virus, I can understand why it works for blood cancers because that's in your blood. How do we envision this working for, say, breast cancer? Because cancer is not in your blood, right?
So you brought up a very important point. So
Okay.
the reason
Oh, good.
we've had good success in blood cancers is because once you put these cells into the blood, they circulate all over the body. So wherever
Hmm.
the cancer cells are, they're able to get it. And if the cancer cells are also circulating in the blood, you're able to kill them better, or they're in the bone marrow. What the challenge that we anticipate and we've run into with solid tumor cancers is because when cancers grow in an organ, they create an environment where it might not be as conducive to have some of these cells get into the tumor and be able to kill the tumor cells. So
Okay.
that is something that's being looked at as to what would be the optimal way of getting these cells into the tumor cells.
Okay.
Is it just as simple as infusing it into the blood, or do you have to do a little bit of radiation to the tumor before you infuse those cells? Or some people have looked at into direct intratumoral injections of CAR T cell therapy to overcome some of those barriers. So hopefully in the next few years, we'll learn a little bit more about how
Yeah.
we can get over that immune space that the cancers create around them, or shield that they create again around themselves, that the CAR T cells might not be able to break through as easily. And that's why we haven't seen as much data come out in solid tumor cancers as of yet.
Okay. See, I'm good at asking the questions. I'm not so good at finding the answers. So this is why we need people like both of you. So appreciate that. Okay, one more question for you, Dr. Deal, with, well, not promising I'm not going to ask another one, but another one in this topic right now that we're kind of talking about the future of CAR T cell therapy. So I know you were saying that if we can kind of get these cells quicker, that would improve the patient experience. But is there anything else that were in these advancements that would then benefit the patient's experience with this treatment?
So I think it's a multi-pronged approach again for this to help improve the outcome. So there are a few different things that we can do better. One, like Liz mentioned, getting early referrals to centers. Right now, not all centers have enough experience, or not all clinics might have the resources to be able to manage these patients appropriately. So as we can expand that and have these therapies available at other centers, that might help. Some of the patients might have to drive a few hours to get to a center where CAR T cell therapy is offered and get treatment there. But in that situation, what is being helped a lot by the drug companies who've developed these therapies is to provide some support to the patients and their caregivers to be able to stay within a certain drivable distance around the cancer center, because they have to have back and forth in terms of their follow-up after they get CAR T cell therapy. So I think helping not just the patient, but also figuring out what their caregivers might need to help support them through this, that is an area of unmet need right now that is being looked at. Also, as we develop more ways of improving the cells, so right now we've looked at patients who've gone through chemotherapy before they get CAR T cell therapy, but are there ways, certain tumors that might be more responsive to immune therapy rather than chemotherapy, that we can identify patients early rather than exposing them to chemotherapy that might not work? So we might be able to bring those patients earlier on before some of their immune cells have been damaged with chemotherapy. That might help. Or using the donor cells, like I referred to earlier, that you don't have to wait for the patient's own cells to grow and expand. That might be another way of helping improving outcomes. And as we identify more targets for different types of cancers, I think that'll help expand this field a whole lot. And then there's a whole other set of research that's happening in terms of the post-treatment outcomes, in terms of some of the side effects, what can be done to recognize the side effects early so you can intervene early to prevent them. Or if patients get side effects, what can be done better to help mitigate those side effects? Who are the patients who might have problems with their blood counts? Who are the patients that might get infections? What can be done to help prevent those infections, whether it be antibody treatments, be it antivirals, antifungals, or waiting a certain time and revaccinating them against some of the vaccine preventable diseases.
Sure. Yeah. So Liz, I'm going to come back to you. And I know we kind of touched on this a little bit, but for those who are listening who might not have been through a treatment, or they don't know anybody who's been through a treatment, so how does CAR T cell therapy differ from the standard of care?
Oh, okay.
Sorry, if I'm throwing you for a loop here.
Good question.
I hear a lot. Standard of care kind of keeps being thrown a lot around. So if you feel comfortable, if you want to explain what that means as well for people who don't know what that means.
Yeah, sure. I think maybe what you're trying, or what the question is alluding to, is how is this treatment different from other conventional types of cancer treatment? And I think when you think of receiving a drug in any normal setting, right, you kind of think that it's readily available, like off the shelf. It's like a chemotherapy product. You go to the infusion center, it's a product that's readily available to be given at whim.
Right.
This, CAR T cell therapy is quite different because it's a multi-step process that truly requires a village to bring to patients. It requires tight communication between hospital organizations and the manufacturer itself. We talked about some of the logistics of, timing of referral, timing product manufacturing, but the process involves, cell procurement, manufacturing, infusion, and then monitoring. So it is different in that it requires more time to actually receive the treatment. It's not readily available. And again, tight communication between treating centers and manufacturers on product availability, because absolutely the patient is first and foremost. And so communicating about what patients might need their needs might be in the interim is really key. So I hope that kind of answers the question, that it's not like a pill that's like ready to go, or a product infusion like a chemotherapy that can just be delivered at whim. It's something that very much has to be coordinated into a larger treatment plan.
So you answered my very poorly worded question perfectly. So, so I appreciate
One
that.
more thing I think the patients need to realize is this is, even though it requires all of that coordination, everything else that's done, but it's one-time treatment. It's done. And if patients respond well, this is not something that requires an ongoing treatment that needs to continue on an ongoing basis. So you just infuse those cells one time, and you expect that those cells will get rid of the cancer cells, or hopefully stay in the body for a period of time to get rid of more of the cancer cells, or maybe provide kind of a surveillance by which any cancer cells that are coming back can be killed or removed by these CAR T cells that are still in the body.
Yeah.
That's an excellent point.
So, well, I am fresh out of questions. Is there anything that either one of you think that I missed that might be important to mention in this conversation today? It's okay if you don't have anything. I just wanted to throw that out there.
So I think one of the things that we still need to talk a little bit about, or I think the patients need to be aware of, is that this is a therapy that's relatively new, and sometimes we run into trouble with getting insurance authorization approval in a timely manner. So I think that is also unfortunately hindering some of the patient care sometimes, or delaying patient care, because this is a novel therapy. It is an expensive therapy out of the current time. Hopefully the prices will come down in the near future. But initially it's gotten a little bit better over the last few years. But initially when this therapy came out, trying to get a patient a commercially approved CAR T cell product, you had to give all the information to the insurance, wait for them to get back to you whether they're going to authorize or other tests that were needed. And that was adding another set of delays to a therapy that might take a long time before the patient can actually receive the therapy. So I think organizations like American Cancer Society has done a great job, and the companies that manufacture and patient awareness and patient advocates have done a great job of raising the awareness of this therapy, so that the insurance companies now, they don't get taken aback when they see that somebody is requiring CAR T cell therapy. But still, some of the insurance companies, especially the smaller insurance companies, still have to go through a contracting process before they're ready to let a center provide this therapy for a patient. So I think that is another area where I think patients and their caregivers can be more vocal and talk to some of the organizations that can help make sure that this is the insurance companies are aware and able to get authorization for this quickly.
Sure. Is it too simple to say that basically, insurance companies are so used to seeing, chemotherapy or radiation as the typical treatments for cancer, and so if they'll approve that, but anything kind of outside of that they kind of balk at a little bit and have to do a little bit more?
I think it's because
research, essentially.
It's a novel therapy, so they want to make sure that it's an expensive novel therapy that is the awareness needs to be raised. They need to understand that this is a therapy that is one time, that once patients get it, if they respond, that they might not require other treatments down the road. So
sure. And so are you seeing, I don't know if you can answer this question or not, but are you seeing that a lot of insurance plans are kind of moving towards covering CAR T cell therapy, or is it still very much a struggle?
Luckily, at our institution, we have a whole team that works with insurance companies. So we are a transplant center. So we had contracts in place with a lot of our big insurance companies in the state of Michigan. And I think a lot of centers have done that, is proactively reach out to them so that there's contracts already in place. When members who have that insurance need to get therapy, they're able to come to certain centers of excellence and get that therapy done quickly, rather than having to wait for a contract to be negotiated between the insurance company and the cancer center.
Great. Well, I always throw this kind of out at the end. If there's something, is there any place that, so to get a hold of me, for our listeners, I think people should know this, but it's Molly Maidenblick. So it's molly.maidenblick cancer.org if anybody has any questions. So my role is to kind of bring these advocates, their voices to the state legislature here in Michigan. Or if there's just any questions on how to get more involved, that's what I'm doing. That's what my role is. But is there if people have more questions about Karmanos, is there a place that they should visit, Dr. Deal, like a website or?
Yes, so we're part of McLaren Healthcare Corporation, and we've kind of tried to reach out to a lot of the state to have centers available where patients can get quality care. So right now we have 16 cancer centers that are providing care, and not all have CAR T-cell therapy available at their centers, but they're able to refer those patients down to Detroit to be able to be assessed for CAR T-cell therapy. And for patients, if they need, or their caregivers, if they need more information, Karmanos.org is our website where they can get more information, or 1-800-Karmanos is the number where they can call and make an appointment to be seen by one of the physicians in the Karmanos network. And we can provide more information and see whether that would be an appropriate diagnosis where we can offer CAR T-cell therapy or other cellular therapies, other clinical trials that they might benefit from.
Great. And Liz, kind of the same questions are replaced. I know Bristol Myers Squibb is really doing a lot in this area. Is there any place if people have more questions that they should go to kind of look for what BMS is doing?
Yeah, I think Bristol Myers Squibb does have 2 commercially available products now, but that's a small portion of what's available across the landscape. And again, we have a number of ongoing clinical trials as well. And I think there are a lot of exciting things going on in the BMS pipeline, but in the industry as a whole. And so if people have interest in looking at what BMS specifically is working on, they can absolutely go to the bms.com website and investigate. And I think
wonderful.
In general, we're at the tip of the iceberg here. And I think every year, every 6 months, every 3 months, really exciting discoveries are being made. And I do think there is a lot of promise in CAR T-cell therapy, and we're just kind of cracking the nut on it. So it's exciting, an exciting time to be involved in it for sure.
Wonderful. Well, I know, BMS and Karmanos have been wonderful partners with the American Cancer Society, and I'm just so happy that you guys were willing to join me for this. So I know we have a doctor and a nurse practitioner, so I'm sure you guys are much busier than I am. So I don't want to keep you any longer. So I really, really, truly appreciate it. And don't be strangers. I hope I didn't traumatize anyone too much with this almost 45-minute long podcast. So thank you both again.
Thanks, Molly.
Have fun. Yeah.
Thank you.
Thanks, Molly. Take care.
Bye.